if we want to move to a target weight or whatever figure we want, sometimes we need pharmacotherapy also. Almost 988 million people live with obesity, and with the westernization and not even in the developing countries, we are having this obesity pandemic. All the research which is in the last 4 or 5 years, it has been on the either the single receptor, which is the GLP-1 receptor, or dual receptor, which is GLP-GIP, or maybe triple receptors, GLP, GIP, and glucagon receptor. As we can see, that GLP agonist is at the backbone to some of the latest research also, in which up to 28% weight loss has also been seen with a triple receptor agonist.
Hello, thank you for tuning in. If you want to come back to this video later, just tap on the like button. It will save it to your like videos so it's easier to find. And don't forget to hit on the bell icon to get notified whenever we drop new content. Stay curious, keep learning, and see you on the inside.
Thank you, Dr. Sanika, for a nice introduction. And it's really a pleasure to be on board. I think this is first time that I'm on Medflix, but definitely I will look further for other opportunities. And I think the topic that has been given to me is quite an interesting one, which is close to my heart. And I'll like to do a justice to the topic by making it brief and simple. And then I'll try to finish quick slides, and then I'd like to have an interactive audience so that we all of the audience can benefit from it. So I think I'm audible and the slides are visible enough.
Yes, sir. All good.
Okay. So let me move ahead. So the topic itself is very interesting, that beyond the scale. So many a times we think that we are overweight or obese or we are conscious. So, and despite our best measures, we are not able to just target the scale to our expectation. So if we want to move to a target weight or whatever figure we want, sometimes we need pharmacotherapy also. So with this in backdrop in mind, I would like to introduce the concept of the uh, obesity drugs. And before that, as all of us know that there is the obesity burden is huge. Almost 988 million people live with obesity, and with the westernization and not even in the developing countries, we are having this obesity pandemic, and that's why if every nook and corner of state or city wherever you live, we'll find that obesity is a global problem. So now if we talk about the therapies, I'm coming straight to the therapy. I'm not going into the detail of how to classify or how to do that. So if we talk about the newer aspect, because there were many drugs which came, which went, but now all the research which is in the last 4 or 5 years, it has been on the either the single receptor, which is the GLP-1 receptor, or dual receptor, which is GLP-GIP, or maybe triple receptors, GLP-GIP, and glucagon receptor. As we can see, that GLP agonist is at the backbone. Okay, so if we have a GLP-1 agonist and we combine it with a GIP antagonist, then we have synergistic effects. Similarly, it can be combined with other agonist, which is amylin, in which we'll come to know. Sometimes there is dual receptor agonism with glucagon receptor agonist, or there can be triple receptors also, in which GLP-1 agonist, GIP agonist, and glucagon agonist. So we'll see these things, and basically it comes to our mind that we are using so much molecules, which is more insulin releasing. We will see that what is incretin effect. Incretin effect is whenever any glucose substrate is taken, so it increases insulin. So glucose is having insulinotropic action, but the effect of GLP-1 in insulin secretion is up to 22%, and GIP is the most potent, contributing to as much as 44% of insulin secretion. So this is very important to understand that not in every case that glucose dependent insulin secretion will be same for a newly diagnosed diabetic, or maybe in further cases of diabetes also. But if we talk about the other aspects of the insulin secretion, and we take two molecules like GLP-1 and GIP-1, definitely the insulin-tropic secretion will be better, and it will be good for that diabetic patient as well as for the other patient. Now, I would like to bring to everyone's attention that some effects are predominantly by GL, GLP receptor agonism, which are mainly at the central nervous system, pancreas, stomach, and the liver level. If you talk about the GIP agonism, the action is mainly at the level of adipose tissue and the skeletal muscle. That is an extra added action because both the molecules are decreasing the food intake. One is increasing the nausea, but other is actually decreasing the nausea. That's why the effect of a double agonist is lesser. So we have dual receptor agonists, which are very good in terms of efficacy and safety also. So moving further, so if some patient or anyone asks us what are the available options, what we have to uh, the expectation of with the lifestyle therapy, with the drugs which are now no longer used. Now, if we see that with lifestyle intervention, with whatever intensity, at least we can achieve 5% of the weight loss. And the drugs like naltrexone, phentermine, topiramate, they were tried, but now they are no longer used. So what is basically active at present is tirzepatide and semaglutide. So with tirzepatide and semaglutide, which are mainly available in the market, in the strengths up to maximum strengths are also available. So these are the epitome of the pharmacotherapy that if we want to target a weight loss of 16 to 20%, we can use the drugs, and we can avoid surgery, bariatric surgery for those patients who do not want surgery in this case. So definitely I would like to highlight that it's not that if you are failing on the drug lifestyle, you do go to surgery only. Much is the research that is coming, and whatever the existing research is, we can at least achieve a weight loss of around 16 to 20%, which is as good as some milder forms of bariatric surgery procedures. So, why are we so concerned about the weight loss? Now, this size is very important because the degree of the weight loss has good effects which are both dose dependent and tissue dependent also. Like if somebody, like these are the various organs on which the benefit of weight loss will occur: liver, the cholesterol, the beta cell function, muscles, adipose tissue, and whatnot, the inflammation markers and all that. Now, if we see that at least if we receive at least 10% of the weight loss, we are having good effects at all the organs. And especially if the weight loss is around 16% or 15%, there is pronounced effect on the liver triglycerides, the beta cell function, the muscle insulin sensitivity, and also on adipose tissue sensitivity and inflammatory markers. So this is something which is very important, that the degree of weight loss that we get will help to improve the tissue dynamics, or the anti-inflammatory action will benefit the inflammatory milieu of the obesity disease. So this is what it is. On the left side, we can see that nutrition, medical therapy, or exercise, or whatever it has a ceiling effect up to 5%. And if we want the surgery effects to more than 25 to 35%, we have this weight, the bariatric surgery weight loss. Now, what what is the option for someone who does not want a surgery and who wants more than the lifestyle surgery? So I think pharmacotherapy is the answer to it. As I told that already the drugs which I highlighted are having a weight loss efficacy of around 15 to 20%. And we have some newer drugs and some newer trials which are showing more effects. Like I'll talk to some of the latest research also, in which up to 28% weight loss has also been seen with a triple receptor agonist. And even it's not that with these drugs doses also semaglutide and tirzepatide that this drug is not achievable. It is achievable in some percentage of patients, which I'll go through as I move ahead. So moving ahead with the semaglutide. So we all know semaglutide comes in various strength, starting from point two, 0.25 to 1, and then 1.7 and 2.4 are the additional doses which are approved for weight loss in diabetes patients. So semaglutide up to 1 mg is Ozempic, which should be very clear, and semaglutide up to 2.4 is Wegovy. So these are the two generic name is semaglutide only, but these are two the brand names for different type of patients. So this is a once weekly injectable GLP-1 receptor agonist. It's a full receptor agonist. And so, what are the expectations with uh, with the highest dose of semaglutide, 2.4 mg, as compared to lifestyle? So these are the data from the STEP trials. STEP trials were done for semaglutide. So as we can see, these are the main gist in which the maximum degree of weight loss, or we can say the mean weight loss that was seen with semaglutide 2.4 mg was 18.2% only. So I must not say only, because it is only only one part of the figure, because in at least one in every five patients, uh, some degree of benefit was there in all the parameters, not only weight but other cardiometabolic parameters also. And 33% patients, or one in three patients, had achieved more than 20% weight loss also. And it is also equally important that there was sustained weight loss over 4 years. So many times patients come and ask me, sir, ये तो नया molecule है और इसके side effects होंगे. What is the data behind this? So I must tell the audience that the semaglutide was initially launched for diabetes in as early as 2012 and 2014. It was the sustained 6 trial and the Pioneer 5 trial, which were trial in the diabetic population, but the molecule is as known as 11 to 12 years back. So it's not that it's known. So we have a robust data, and of course the data is evolving as regards the obesity and other things also. So this seems a very busy slide, but I'm not going to go through each and every step. I just want to let know that the trials that were with semaglutide for MG were step trials. Like we have different type of step trials. Step one is only for weight management against placebo. Step three was weight management with intensive therapy. Step four was with subclinical weight management, and five was long-term weight management. Like that, many were there. And the horizontal, the vertical bars that we are seeing, the dark blue, navy blue bars are with semaglutide. And as we see that the largest uh, uh, this depth of the bars are with the semaglutide 2.4 mg, which is expected as compared to semaglutide 1.7 and liraglutide. So the mean weight loss was around 18%, which I already told in the previous slide. Now, people thought that uh, if if we are having good benefit when we are increasing the dose of semaglutide from 1 mg to 2.4 mg, what happens if we increase the dose further from 2.4 to 7.0 mg? So this was a step up trial, again a step up. So for evaluation of obesity, and the patient uh, were further given 7.2 mg dose after the reaching of the 2.4 mg dose. So what was it? So now in this, there we saw that at least one in three patients had achieved 20% loss with 2.4. Now in this, one in every three patients treated with the highest dose of semaglutide 7.2 mg once a week may achieve more than 25% of weight loss also. And with this, the mean weight loss reduction is 3 or 4% higher. There it was 18% or 70% maybe, but here we are having a weight loss of 21%, which is at least absolute terms, it's 4% higher also. So, oral semaglutide, we all know, is available in the name of Rybelsus in strength of 3, 7, and 14, which is commercially available. But trials are there with oral semaglutide 50 mg also. Again, form of stepping up like, but these are the Oasis trial. And in fact, in this newly evolving obesity market, Novo Nordisk had applied for FDA approval also in April 2025 as recently. So the efficacy of the oral semaglutide 50 mg was again like the semaglutide 2.5 mg, at least more than 20% weight loss was seen in 1 in 3 patients, 15% weight loss was seen in 50% of the patients, and around 66% patients had 60 to 70% patient had at least 10% of weight loss. So this was it. Now, this is again in the research oral non-peptide GLP-1 receptor. I'm not going to detail. So, coming to things which are already available in the market, it is like semaglutide and tirzepatide, which is well known by Monjaro. Zepbound is not available in India. Actually, Monjaro was approved for uh, type 2 diabetes patients, and Zepbound was actually approved for or given for those patients who were obese, irrespective of their diabetes status. Now, again, this is a weekly injectable, but it's a double receptor agonist, GLP-1 plus GIP-1 agonist. So, the trials that were seen with tirzepatide were the surpass trials in the diabetes subset, and for the obesity subset, it was the surmount trials. So it's very easy to remember, like obesity, O is coming in surmount. So surmount trials were the obesity trials, while surpass trials were the diabetes patient trials. So in the diabetes arm, the weight loss that was seen was around 8 to 12%, or maybe up to 11 to 14%. But in the obesity trials, the weight loss was a bit higher. It was around 18 to 20% also. And we all know that tirzepatide is approved for patients with obstructive sleep apnea syndrome also. Now, again, these inverted vertical bars in the surpass trials, in the surpass 2 and surpass 5, these were the head-to-head trials. Surpass 2 was in diabetic population in comparison with the semaglutide. Surpass 5 was in the again diabetic population in comparison to somewhere. While surmount, we can see that almost 21% weight loss was there. Now the yellow graphs are the longest because the yellow graphs represent the tirzepatide 15 mg, while red graphs are the tirzepatide 5 mg. So we can see again a dose dependent effect. As the dose are increasing, we are having a greater effect on the effect of that. Now, because Surmount 1 was the obesity based trial, so in Surmount 1, so we see that two-thirds of the patient on Manjaro 15 are experiencing more than 20% weight loss. So if you talk as compared to the semaglutide, in the semaglutide arm, it was at one-third patients were achieving more than 20%, but here it is two-thirds. We cannot compare because it is not a head-to-head trial, but definitely the degree of weight loss, if used in per se for 32 weeks, is higher with mother. Now, as I highlighted in the first slide, that we can combine GLP-1 with GIP. We can combine GLP-1 with amylin analog also, which is peglutide. So this is a combination Pagri plus Sema. Pagri is short form of peglutide, while Sema is short form of semaglutide. So peglutide is also being developed. The trials for peglutide are the redefined trials. So many trials were there. We defined 1, 2, 3, 4. So I'm not going to each and trial details, but just want to highlight the fact that in patients with obesity with diabetes in the redefined 2 trial, so this March only, it achieved the primary endpoint of showing a significant effect of around 15% weight loss with cagrisema as and the minimum weight loss of 5% or more was achieved by at least 90% population. Now, this is again a bit higher because in the semaglutide studies, we saw that at least two-thirds of patients were achieving or 66% patients were achieving weight loss of around 10 minimum of 5% or and 10% was around 70%. So this is also showing promising results. Further redefined trials are in patients with cardiovascular disease or versus head-to-head with this tirzepatide. Yeah, so it is quite good that the trials were basically targeted against the obesity-based things. Now, this is retatrutide. Again, the true word stands for triple receptor agonist. True means true. Uh, triple receptor agonist. Just we can remember like that. So retatrutide, and I would like to highlight a very important fact. So yesterday only at 11 December, that trial with retatrutide are the TRIUMPH trials, and if we see in the TRIUMPH 4 results, the this is the latest triple receptor agonist, and although it seems a very busy slide, but I like to highlight that the figure that I have tried to highlight is a 28% weight loss with this in this trial. So let's see what things are coming up. But just wanted to add this latest development of triple receptor agonist, which came yesterday only. So, not wasting any time further, as I just wanted to touch upon the things and more participate in consultation of regarding the drugs and a conversation direct one to one. So, I like to come to my final conclusion slide. We all know that it's a pandemic. No doubt, it's a pandemic not for only the developed countries but developing also. So, in if we talk about India, we at present we have oral semaglutide in the form of Cerevelsis, then Wegovy and Ozempic from Novo Nordisk, and Mounjaro from this Eli Lilly. So this recently available drugs have actually given us a hope that for those patients who are more than 100 kgs, we can use it. And as I highlighted, glutathione data have just come up, and oral GLP-1 receptor agonists are also being developed, like or for glipron and other things. We'll have to see what the data is. So let's have a good hope that we get to know about other drugs, and we'll have a good data about the obese patients and other non-obese benefits also. Like many of these drugs who are having a good effect are having good effects on metabolic associated systemic liver disease and steatotic liver disease, PCOS, in osteoarthritis, and whatnot. So I think targeting the core problem in obese patients, which is the weight, will help in direct regulation of the diseases. Also, it will help in indirect decreasing of the inflammatory milieu and other things also. So, with this, I'd like to come to and thank you for the patient hearing. I'll be happy to answer the questions, queries, and would be willing to participate in any interactive session that we are having.
Yes, sir. Thank you so much for your presentation. We have had a couple of questions that have come in during the session.
Yeah.
While we wait for more questions, we can take them one by one.
Hmm.
Dr.
Actually, I
Mansoor,
wanted to. Actually, I wanted to end up not with many slides, but otherwise there is part of discussion becomes very shortened. So I think this should be discussion more rather than me teaching more.
yes, sir. So the
So,
first question here is Dr.
Dr.
Mansoor
Mansur.
Shah has asked semaglutide, obesity, diabetes, oral dose, and the effectiveness of the same.
Okay. So the doses that are available for oral doses that are available for patients, it's not approved in obese patients. It's approved for those patients who are either pre-diabetic or diabetic and are obese. So by obese, I mean either the BMI is more than 30 or BMI is 27 to 30 and they have some comorbidity in the form of hypertension, dyslipidemia, any CAD event or something like that. So the doses that we start usually are 3 mg, and it is very important to educate the patient that patient has to take the capsule in the empty stomach with around 200 ml of water, and the patient should not be lying down after taking the tablet. It should be at least upright for 1 hour or so, and he should not be taking any form of capsules or thyroid tablet because though both these medicines have to be taken anti-stomach. So what I advise the patient, take first the semaglutide oral or Rybelsus. Then after 1 hour, you take the thyroid tablet. Then you can take the oral capsules or something more because you need acidity for thyroid also.
Sir, the next question has come in by Dr. Mahadev Desai, sir. It is, what are the contraindications and precautions before starting these newer drugs? What should we keep in mind?
Thank you, sir, for asking this. I think I missed it in the slide because I truly concentrated on the newer drugs. So it's a nice question. So precautions that are very important is first counseling the patient about the gastrointestinal side effects. I usually what do in my practice is that I tell the patient that whenever we eat like fatty foods like paratha, chola bhatura, and all that kind of things, our stomach fills for like 3 or 4 hours because the stomach emptying is delayed. So in that way, I always tell my patients that after eating it, most of the things will remain in your stomach. So you may have GRD symptoms, you will have burps, you will have uh, postprandial fullness. So these are the things which you need to be careful about. The nausea and vomiting in some cases. Some patients also complain about vomiting. But all in all, these five are things are gastrointestinal only, which can be mitigated by starting at the lowest possible doses and then starting gradually. Then I ask about history of pancreatitis, whether any history of pancreatitis is there or not, any history of thyroid cancers are there or not. I do advise a fundus examination, retina checkup, because these drugs are not to be given if the patient is having active eye disease, active macular edema, or proliferative retinopathy. And even a patient has mild eye disease, we can start, but we have to convince the patient that he has to do repeated eye checkup so that he does not miss on any active disease.
Moving on to the next question that has come. Dr. Dinesh has asked, what are the limitations of oral obesity drugs?
I think the biggest limitation is the degree of weight loss. I have not seen a weight loss of more than 5 to 6% with these drugs. And the other limitation is the significant side effect. Many patients are not able to tolerate because of gastro side effects. So these are the two big limitations. The efficacy is a bit lower and side effects are higher.
Yes, sir. Thank you. Dr. Narendra Patel, sir, has asked a couple of questions. I'll take them one by one. So, what is your opinion about oral semaglutide?
Oral semaglutide is a good drug for those patients who fear of injection. But I think it will be better to select this drug as a drug for reducing the risk of ASCVD events like heart attacks and all that, and use of drug for its GLP benefits, reducing the insulin burden or maybe the diabetes tablets burden and some some benefit in weight loss. We should not look it as a weight loss drug because many patients tell that yeah, हमारा weight loss हो जाएगा capsule खा के, but it's not like that. It is having more diabetes or cardio benefits rather than weight benefits.
Thank you, sir. Uh,
Mostly.
Next question is, are we supposed to continue the medication once we reach the target weight loss?
Ideally, what has happened after stopping the GLP-1 based therapies is patients do have a rebound weight gain. So the label for these drugs is to continue them for lifelong. But all of the audience and I think both of us will also agree that it's not possible for the patient to continue for lifelong. So what ideally what I think is I counsel the patient कि अगर आप 100-120 किलो के हो तो you shed some kilos, reach around 80 to 85, and at that time maintain with the maybe minimal dose, or you can manage with your strict diet and exercise routine. So I think 6 months to 1 year is a good time because beyond that the patient will not be able to continue it because of cost issues.
Yes, sir. And what are the side effects or the complications that we could see by from a GLP agonist?
The complications is just worsening of retinopathy or macular edema if we are giving to a severe diabetic retinopathy patients. The side effects, as I told previously, they are basically because of decreased gastric emptying. So they may be worrisome for those patients who have GERD symptoms because that will increase the reflux. Then again, they will have all those patients who have a history of thyroid, maybe thyroid cancer in themselves or in their family, there may be a risk of it, which can be mitigated by doing a serum calcitonin test, which is a marker of medullary thyroid cancer. One thing that is there. And other is that the history of pancreatitis. If someone has history of recurrent or acute pancreatitis, it's better not to give them.
Thank you, sir. Uh, we we had a similar question earlier. So, can we use semaglutide in an obese patient with hyperglycemia
Yeah, definitely.
and
But
without
it,
hypertension?
it, it is injectable one, not oral one. People are using, but that is something which is not labeled.
Yes, sir. And continuing it further, if for a cardiac disease patient, is there any extra care that we should consider while giving
I,
such drugs?
I think these are the two good drugs in a cardiac patient. So we should definitely be going for these drugs in a cardiac patient because if we see the recent ADA, American Diabetes Association algorithm, the 2026 or whatever it is, these drugs are because now no longer there is a glucose-centric approach, there is a patient-centric approach. So if patient is having a ASCV event or heart disease, it's better to start GLP-1 therapies. If patient is having kidney disease, start with SGLT2. If patient has heart failure, again SGLT2. So in that arm, if you see, if a cardiac history is there, the first drug that is to be given is GLP-1 based therapies, even before metformin.
Yes, sir. Okay. Dr. Farooq Ahmed sir has asked which one of the two, Manjaro or Ozempic, is more effective for a weight loss in on the long run.
So it's a very tricky question. As I told, there are two head-to-head trials of these drugs. Uh, one is the Surpass 2, in which tirzepatide was compared with semaglutide. But there, because it was a diabetes trial, so the maximum dose in a diabetic population is 1 mg for semaglutide, right? And tirzepatide can be used up till a maximum dose of 1.5 mg. So comparing 1.5 mg tirzepatide with 1 mg of semaglutide, in the tirzepatide arm, the weight loss was around 21%, but in the semaglutide arm, it was around, I think, 11 to 12% only. So if you compare these two, of course, the tirzepatide will fare better. And in my personal practice, what I think that with tirzepatide, the side effects are a bit lesser because as I told that with GLP-1 the nausea increases, but in with the GLP-1 agonism the nausea decreases. So basically, if you're using both the receptors, the side effects are better. So in the Surpass 2 and Surpass 5, tirzepatide or Monjaro was better because it was compared with Ozempic, which is one mg, but Wegovy is 2.4 mg. So maybe I think both will be equal only. But tolerability, full marks to Manjaro.
Okay, sir. Moving on to the next question. For a patient on thyroxine, how can you suggest to take and how should we take semaglutide?
Yeah, that's what I was saying. As the patient gets up in the morning, first he should take the oral semaglutide and then wait for 1 hour, and then after patient can take thyroxine.
Yes, sir. The next question
I think
is
questions are quite there, so it's good that we are having an interactive session.
yes, sir. We have quite a few more questions, sir.
Yeah, yeah, no
Uh,
issues.
s- Sir, in the trials, Dr. Rupanshu Mehra has asked. So there are trials showing around 20% of weight loss. So is it possible in reality to achieve this, and how much will the duration of the treatment be?
Dr. Rupanshu, I'll be sharing the real world data. It's not a trial based data. So, in many of my patients, one of my patients who is taking is 166 kgs. I've started her on, she's a female. I've started her on this Monjaro. So, she has lost around 14 kgs. So, the maximum weight loss that I've seen uh, is around 8 to 10% only. Okay. But right now, many of my patients are on the like third or fourth month of therapy. So I've not gone till maximum doses. But going by the facts that they are achieving at least 50% of what is expected, they are reaching at least 10% of the weight. So maybe the higher doses, I think 50% is achievable for that, if not 20%. So I would love the patient even attains a weight loss of 10 to 15%. That is okay for me.
Yes, sir. The next question is by Dr. Mahadev Desai, sir. Can we give these drugs in patients who have underwent the bariatric surgery and have now started gaining weight?
Yes, ma'am. Yes, sir, we can give it. In fact, in many of the trials, they have seen the efficacy of semaglutide even before going for bariatric surgery. But of course, giving these drugs before surgery is an issue because of the gastric emptying issues. And if the patient is having rebound weight gain, in many scenarios, these drugs have been used to to use to use for weight loss.
Dr. Ayush is asking, what are the important and commonly seen drug interactions we need to be aware of while giving the GLP-1 agonists?
I think many of the diabetic patients will be on DPP-4 inhibitors like sitagliptin, vildagliptin, or linagliptin. So it's better not to avoid because we are already using a GLP-1 based therapy. So I think first we should be very particular of not using those drugs. Then the other thing can be if the patient is going for surgery, elective surgeries, or is going for general anesthesia, it's ideally these should be stopped at least 1 to 1.5 months before the surgical procedure. But if some emergency surgery is there, or maybe short span is there, at least two doses should be missed. Nearly 2 weeks gap should be there. So that is very important because that will increase the chances of gastric aspiration.
Thank you. Dr. Pankaj has asked, what is the ideal diet and routine for severe obesity? And
I think he's asking about only obesity, not on only pharmacotherapy. I think the most important routine, the bare minimum thing uh, is eating at proper times. Many of our mother or parents they think कि 2 बार खा लो ठीक हो जाएगा and mummy and बाकी लोग they do like they are busy doing puja and they do breakfast at 11 or 12 and then they'll keep on taking tea and all that. So many of the Indian households are used to eating at irregular timings. There is a improper gap. So I think the most important thing that I tell my parents, my parents as well as patients, is that there should be a proper gap of 6 hours between the three major meals, like breakfast, lunch, dinner, and there should be snacks in between. Another thing is we are a carb-loving country. Uh, the matter we start including proteins in our diet, we start including complex carbs. It helps a lot, and we should not be targeting a very intense activity from very beginning because we will not be able to do that. So it's better to slowly escalate your physical activity. So basically, carb less, more protein, more complex carbs. That is what I want to convey.
yes, sir. I just wanted to continue it with one more question that I had from a previous answer. Is that after the initial semaglutide or GLP-1 agonist therapy, what should the diet be and what should the ideal diet look like?
So the diet, if somebody is on injections, the ideally the patient should not be taking a very high fatty diet. Okay, because fats also decrease the gastric emptying, And if you're taking these injections, these are also taking the gastric, decreasing the gastric campaign. So you'll be able to feel the nausea and other things very much, GERD symptoms very much. So I think it should be fat, minimal diet, and it should be small, frequent meals rather than too heavy meals. Because more the heavy meal, more it will be the GERD symptoms. So that is very important. And protein intake and resistance training is a must because otherwise, with the weight loss, there will be some degree of sagging of the skin and other undesirable side effects, which can be taken care of if you take a high protein diet, do some resistance training also. They are difficult to do, but they need to be done.
Thank you. Now moving on to the next question. All these drugs to be given for persons of BMI 30 or more, or can it be also given for more than 27 BMI and not below it? What should the ideal BMI range be?
I think he has asked. Actually, the ideal BMI range is 27 to 30 with comorbidity or more than 30. And if you ask me in my practice, I would prefer only for those who are having BMI of more than 33 or 35. Because sometimes patients come to 95 weight, I have a marriage, I have something, I want to get in. So I think these are not the conditions. I ask them to do intense physical training rather than take these drugs.
Yes, sir.
That's my perspective.
Yeah. Sir, another question about comorbidities. Any
Okay.
dose adjustment is required for hypertension if the patient
No,
is on
it's not.
semaglutide?
It's not required for those with. In fact, it will benefit. Tirzepatide has shown a BP reduction of around 2 to 3 mmHg. And again, the effects on BP or whatever it is, diabetes, PCOD, MSLD, all these effects, good effects are due to weight loss. So I think if there is significant weight loss and the patient is having BP in the lower end, maybe we need to lower down the BP, but usually we don't need to.
Thank you. A couple of more questions, sir. Sir, can we give Orlistat or with sema or tirzepatide, and will there be any benefit?
Yeah, I think Orlistat can be used if the patient can tolerate it. There is no harm because the mechanism of both the drugs are different only. So I think it will add to the effect. There is no harm in adding it to any of the drugs.
Sir, can we use acarbose in with semaglutide?
Yes, you can use.
Okay. Will that have any added benefit?
Uh, Sema-acarbose basically increases the postprandial sugar. Sorry, decreases the postprandial excursion. So maybe if the patient is having significant increase in the PP values, postprandial values, so maybe that it will be helpful.
Okay, sir. Those are all the questions till now. If there are any questions, please feel free to write them in the comment section right now. We'll take them up one by one. Sir, in the meantime, can you list down a couple of important take home messages that everybody should remember about the newer obesity drugs?
Yeah, I surely do. Uh, Actually, the most important thing about these newer drugs is judicious use of these drugs based on doing the preventive uh, checkups. Like eye checkup is a must before starting these drugs. History of mood disorder, depression, psychiatry issues, pancreatitis history, and thyroid cell cancers. These all also must should be addressed before starting these drugs. Now, if you talk about the efficacy of the drugs, then both the drugs may be having a efficacy of 15 to 20%, the injectable ones, in the maximum doses of tirzepatide 1.5 and semaglutide 2.4 mg. And with oral drugs, the efficacy is a bit lower, 5 to 6, but still it's good if someone wants to avoid the injection. And we must remember now we have triple receptor agonists also that I highlighted last day or yesterday only the data came. It was the rate of right. So these are things which I think every audience should be aware of. Now we are not talking of a single receptor GLP-1 SEMA. We have the double agonist, we have the triple agonist. We have agonists, double agonists with ML analogs also, which is cagrilizumab. So this was the gist of the talk that I wanted to highlight.
Thank you so much, sir. We've got two more questions here. Uh, Dr. Rupanshu Mehra has asked, sir, should we routinely use the PPIs or any other prokinetic agents for preventing the side effects?
No, routine use is not needed. If if patient is having more complaints of nausea rather than like bloating or those kind of things, that's what I see. So I will prescribe the patient online cetron mouth dissolving and tell him कि अगर दिक्कत होगी nausea होगा, you just pop a pill below your tongue. That's it. So I think routine use of PPI is not needed. If the patient already has GERD significant symptoms, or he or she is having using this Nexpro IT or Mendocin IT kind of things, so maybe in that case we can routinely continue, but not in every case.
Yes. So, one last question, I think. What are your remarks about injection Munjaro for obesity reduction?
It's a wonderful drug, especially regarding tolerability. Patients are tolerating it very well, and especially for those, I have two or three patients who are more than 150 kgs and is doing very good. See, it's not about the numbers that it is reducing in those who are 140 or 130 above. It's the change in the lifestyle. Previously, they used to come and lift. Previously, they used to walk slowly to my clinic. Now they are able to climb the stairs. Now they are doing gardening in their background, and they are just doing some household chores also. So this is what the real benefit of these injections is. They have not lost weight, but they are very happy that they are getting healed from inside. These are the comments that I get from the patients. So rather than going to the data and all the studies, it will be better what these injections are doing to their lifestyle as a whole. So that is very important. I think this is the most important take-home message. We should not be just going for the numbers. We should be doing some justice to patients' overall quality of life.
Yes. Just continuing this question, sir, what should be the minimal duration be? Like you mentioned, maybe
I think
lifelong.
minimum 6 months, because sometimes you need to escalate the doses. In tirzepatide also, minimum 6 months are needed. Like first month, uh, 2.5, then 5, then 7.5, then 10, then 12.5, then 15. So you'll need at least 12, sorry, 12, uh, 1, 2, 3, 6 doses to reach the maximum dose if someone needs the maximum dose. But it's not in every case that we'll be needing to go to maximum doses. So still, I like to keep the 6 months की therapy तो लेनी पड़ेगी.
Okay, sir. And sir, what about the patients who were started and they discontinued the drugs? So,
Usually, if somebody restarts these drugs, usually it should be started in the same way as it was started previously,
as a new
and
patient.
usually starting with the lowest dose and up titrating. The only benefit will be that such patients will be able to tolerate it better because they have used the molecule before. Like patients who are taking the oral semaglutide repulsors, they are able to tolerate the drug better. One thing. And other thing that I want to highlight in this case is that if somebody misses the dose, like suppose I'm taking the injection every Sunday, and the next Sunday I'm missing the dose. So I can take the injection in the coming 3 days. So total 4 days are there. So next Sunday, next Monday, Tuesday, Wednesday. So till next Wednesday, you can take the injection of the next week. But uh, if you forget the 4 days, you cannot take the injection on Thursday, Friday, Saturday. You have to skip for that week. This is very important.
Thank you so much, sir. I think those are all our questions. Thank you.
Yeah,
That brings us to the end of the Q&A.
it was really good, and I must thank the seniors. I think I don't remember the names exactly, but I think it was a very interactive audience, and hopefully I was able to answer the questions and put some insights. I did not want to put into a great deal of research kind of talk. I wanted to be basic and the common facts.
Yes, sir. Thank you so much.